Buenos días a todas.
Good morning, everybody, ladies and gentlemen. Welcome to this webinar. Today, we have this activity under the framework of the 28 Days campaign, Time for Caring and Loving. It's a campaign that in each of the 28 days of February provided interventions, care, attitudes that have the potential of improving the life of newborns. We believe that the first 28 days need to be full of evidence-based care and love. Today, we are with the decision makers and national authorities that are very important to continue to implement the best evidences available and the best activities for the health of newborns. Before doing so, I'd like you to take your phones and look at the screen to see the code of the app that as part of this celebration commemorating this campaign, we developed an app so that you may all have a direct access to the app. This app that you may download free of charge from either Apple Store or Google Play has information for healthcare professionals and for the parents, users in general. We hope you download that app because it's a very useful tool, no matter what the topic. Do you want to discuss breastfeeding? There's a video there. There are filters. There are possibilities for you to have topics that you'd like to discuss when the patient is discharged or when at the time of a visit. What we intend is that when the mother is discharged from maternity, I remember myself 30 years ago when I was discharged with my daughter. I was already a doctor, but still I had doubts. So I think that each father, each mother, each family is going to find this very useful, is going to upend their lives because this is promoting self-care. Self-care is the most important intervention in a child's health. It's the best technology. I can take care of myself. I can look for evidence. And this app is based on the best evidence available. We developed this together with our collaborator center in Argentina, the Italian hospital, and they promise, as it is usually the case with all the apps, that every day we're going to have more videos, every day we're going to have more content, and you're going to be able to have all these updates. So please download it, use it, and you'll see that you have a tool that is very useful to give the families, the patients, the users. Now, let me give the floor to Dr. De Francisco, who's the director of family promotion and course of life that will present this event and our very outstanding speakers today. So thank you. And please, Andres, you have the floor. Thank you, Suzanne. Good morning, everyone. Thank you for coming, all those who are attending this webinar on strengthening our neonatal policies and interventions to reduce the burden of disease and this in the Americas. Well, you know that, well, I wanted to introduce the seminar to discuss the Sustainable Development Goals that are intended to reduce mortality, maternal mortality from 12 per 1,000 live births in the Americas. The member states of the Pan American Health Organization accepted a plan of action to achieve that level of mortality for the health of women, children, and adolescents from 2018 to 2030, so as to promote the health of all the women, children, and adolescents in the Americas. The regional plan intends to achieve a mean neonatal mortality rates to 7 per 1,000 live births for 2030. That is lower than the SDGs, that is 12 per 1,000. And for that purpose, we need a comprehensive multisectoral actions to reduce the preventable complications for women, children, and adolescents. So countries in the region have made progress in that direction. However, the challenges continue to be quite a lot, especially because of the impact of the 2019 COVID-19 pandemic. That is why we have thought of strengthening actions in that regard. The public policy and society of mothers, fathers, caregivers, and families, we know that they play a key role in that process, and they are a priority to favor health as an asset, as a right. In that regard, today we have the contribution of the experienced speakers. We'll discuss the implementation of policies, their drafting, their implementation, and their enforcement. And I'm going to introduce the colleagues. I'm going to introduce them by name because that is how it's in this order that they will appear. First of all, Fabiano Archini, Executive Director of Canadian Premature Babies Foundation. She's a journalist and she's the author of the book From Surviving to Thriving, The Mother's Journey Through Infertility, Loss, and Miracles. She's going to tell us about her story after struggling against infertility, and she will also discuss the role of the networks and associations of families in the care and protection of newborns. Second, we'll have Gabriela Bauer, pediatrician, director of Perinatal and Childhood Department of Health of Ministry of Health in Argentina. She will discuss Law 1010, care and comprehensive care of health during pregnancy and early childhood. Right after that, Dr. Gabriela Rodriguez Bukele, First Lady of the Republic of El Salvador, who will talk about the policy being born with love. She couldn't come today, but she has sent us her presentation in a video. And finally, Audelia Villarreal, a senator of Mexico, and she is the director of Ayuda de Corazón de Niños, a civil association, a non-profit organization that is devoted to provide highly specialized care to children with congenital malformations of the heart. She will discuss the work and legislation on heart neonatal screening in Mexico and the work Mexico has implemented. You see that it's a very interesting panel. So from now on, we can recognize each speaker, except for the First Lady, who, as I said, will show her video. So without further ado, I give the floor to Fabiana Baccini, Executive Director of Canadian Premature Babies Foundation. Fabiana, you have the floor.
Thank you, Dr. Andres de Francisco, for the introduction. I'm just sharing my slides here. Good morning, everyone, and thank you so much, Dr. Pablo Duran, for inviting me to be here today to share my personal story and present on the role of the parent organizations to help to create a better future for babies born too soon, too sick, or preterm. My story started 10 years ago when I was expecting twins, and I found out that one of them had a heart condition and zero chance to make to birth. At 26 weeks gestation, I went into labor, and after an emergency C-section, Michael was stillborn, and my surviving twin Gabriel was rushed to the Neonatal Intensive Care Unit, known as NICU, which became our surreal home for 146 days. My first few weeks in the NICU were terrifying. My baby was so tiny and so fragile. His body was wrapped in a plastic bag. The breathing machine was bigger than his face. I wondered how an entire life could be contained in 900 grams. Would he survive? I asked myself, but never dared to ask anyone else. I was overwhelmed and afraid of losing him. I did not feel like a mother. Meanwhile, I had to manage the care of my older son, who was 3 years old at the time, as my husband focused on work to make sure we were all taken care of financially. As the weeks passed by and I was feeling more comfortable in that scary environment, I was invited to participate in a research study called Family Integrated Care, or FICARE, where parents are part of their baby's care team. It changed my perspective in the ICU as I started to see my baby beyond his wires and monitors, to celebrate who he was. It was the first time I felt like a mother. But what really made me feel like his mom? I had education sessions every day to learn about brain development, the importance of holding my baby Kangaroo Care, or skin to skin, the benefits of breast milk. I learned to recognize his needs when he was in pain or hungry, for example. I understood that the more I did for him, he would have a better chances to survive and would have better outcomes despite having very poor prognosis. Being in the ICU is a roller coaster with no end in sight. Everything can change in a split of a second. Sometimes we have to make impossible choices. Mental health support is essential as the trauma can last for years. I received mental health support through a social worker, support groups, and peer mentors. Caring for me was just as important as caring for my son Gabriel. We were considered one of his essential caregivers in the ICU, and we had access to him 24 hours, 7 days a week. What I gained from being involved in his care. By being the most important person on his care team, I gained strength, confidence, knowledge, life skills. I learned how to live in gratitude, and I learned how to advocate for my son. This was extremely important for our journey after discharge, as Gabriel had many readmissions and he was later diagnosed with cerebral palsy. And no matter where you live, having a child with a disability, you have to advocate. The premature journey does not end when babies get discharged. Every preterm baby has challenges when they go home. They are more susceptible to infections, poor feeding, developmental delays, learning issues, and the list goes on. The more educated on potential issues and prepared we are to care for our babies at home, the better we'll do as a family. So what happened next? What happened after discharge? My journey led me to volunteer at the hospital where Gabriel was in the ICU. I wanted other families to know that they were not alone, and as this is a very isolating and lonely experience. Nobody understands the impact of having a baby in the ICU except those who have walked in similar shoes. That experience brought me to the Canadian Premature Babies Foundation, a national parent-led charitable organization providing support and education for families of babies born preterm. My story is only one of millions that happen every year around the world. But every story is unique, and everyone will take a different path after having this NICU experience. For some of us, this experience will ignite a passion to serve others, to ease their burden, and to create change. Our collective lived experience as NICU parents lead us to create or join organizations. There are many parent organizations around the world working together for better care of babies born too soon, too small, or too sick. Overall, parent organizations are involved in and working together with healthcare professionals and researchers to provide services, support for parents, and education that are evidence-based, to identify priority areas in care and research, to advocate for equity, standards of care to improve outcomes, to co-create system changes with policymakers and stakeholders. We work really hard to advance family-centered care and to create public awareness. And this picture is a big group that we meet in Germany every year to really have those sessions and see how can we work together for better outcomes. And as a result of the pandemic, parent organizations create a global call to action for zero separation as hospitals worldwide imposed strict restrictions on parental presence in the NICUs. GLANCE, the Global Alliance for Newborn Care, conducted a survey on parents' experiences from 56 countries during the pandemic. The results showed that 1 in 5 parents did not have access to their babies while in hospital. There was a decrease in breastfeeding and limited access to mental health support. Research has shown already the short-term impact of separation, and the long-term impact can only be predicted. So looking at PAHO's action plan for 2018 to 2030 to address the immediate causes of preventable mortality, morbidity, and disability in women, children, girls, and adolescents, and knowing the impact the pandemic has had in women and babies, there is an urgent need to bring all stakeholders to the table to come up with solutions to immeasurable challenges our continent faces. But you must be asking, why involve parent organizations as one of your stakeholders? And I would say that first and foremost, we have a heart in this field. We know firsthand what works and what can be improved for better outcomes. We see the gaps in the system, we understand the needs, and together we can create solutions. Last year in Latin America, 18 parent organizations had their first meeting with PAHO to discuss their challenges and share their organization's activities in their countries. This, in my opinion, was the first time that we brought all the voices together to explore the possibility of working towards a common goal of having families and their babies not just surviving, but really thriving. And we look at this and you think about, but what can be done immediately to help families, first of all, to survive? And we have to take baby steps because the challenges are immense. So I think the first and foremost is to see parents as parents, not visitors in hospitals. Parents are essential caregivers and should be given access to their babies in hospitals 24 hours, 7 days a week. Well, let's talk about Kangaroo Care. We all know the benefits of Kangaroo Care. That should be its standards of practice. And we should provide a welcoming environment for parents to stay at the bedside, and minimum have a chair by the baby's incubator. Support breastfeeding and access to breast pump, as many families cannot afford a breast pump. Have mental health support in place, and also a discharge planning in place. But we all here want families not only to survive, but to really thrive. But what are some of the immediate baby steps you can take to help families thrive? For all of us who spend months in hospital, we know the financial burden that is to be in a hospital with a baby. We need to provide financial support for families so they can be there, pay for transportation, for food, and look really careful into maternity leave. I know that many countries still struggle to provide maternity leave for parents who have jobs. Also, neonatal follow-up and community resources, especially for families who live in rural or remote areas. Access to prenatal care and education for healthcare professionals to educate families on what is important and how they can help their babies. When I reflect on my own experience, I realize how privileged I was when I started this journey. Despite being an immigrant in Canada, I'm from Brazil originally, I had the financial means to be at the hospital and take care of my son post-discharge. I had to be involved in his care, and I had education sessions in hospitals to know that my son was high risk of having a disability, so I could be proactive and start early intervention immediately to maximize his potential. I had enough breast milk and incredible support to breastfeed. I live in an urban center with access to community resources. I had psychological help to help me deal with the trauma. Today, I can say that my son is thriving, and we are thriving as a family. But my story is one of privilege. But many families do not have a similar experience. That's why I and other parents create and run organizations worldwide to bring all voices to the table, to ensure all families have the opportunity to thrive despite their socioeconomic situation, where their babies were born, or where they live in the world. It might be an utopic dream, but it's only a dream if we dream alone. When I look at PAHO's goals and the intention of this meeting, I know that the goals presented here are our dreams with a deadline. My take-home message today is to each and every one of you to invite us to your table. Sometimes you might need to climb down from your ivory tower, leave your boardroom, and meet us at the cafe where we are engaging, brainstorming, creating movements, campaigns, and programs. It's there where we'll see people, where you hear the stories, where you understand the impact of policies, where you learn from those with lived experience what works and what doesn't work. Let's sit together to create policies, to co-design research, to design hospital settings, to include us in quality improvement projects, to define and redefine outcomes, and to set priorities. The disability community has a saying, nothing about us without us, and the same applies here today. And then, only then, we'll see the change. And I will leave you these beautiful words of this young poet that says, there is light if only we are brave enough to see it. If only we are brave enough to be it. And I truly believe that together we can. Thank you very much.
Muchísimas gracias por esa
Thank you
presentación.
so much for your presentation. Gabriela, the floor is yours. I'm sorry, I can't hear her yet. I don't know if she has the microphone on. She hasn't turned on her mic, I'm sorry. Good morning, everybody from Argentina. Thank you so much, Ajo, and Dr. Ceruja and Dr. De Francisco and Duran and other colleagues in CLAP for calling for this meeting and calling us at the Health Ministry to share this summary of the neonatal policy approach in the framework of this new law in Argentina, 27,611, also called 1,000 days. That is a reason for pride, but also questions us as a state to guarantee the application of rights that the law demands for individuals in this life course. A word of acknowledgement for Fabiana, everything you conveyed, all the strength of your family and the urgent need we have in all our countries to consider that everything we do must focus on what the families of our children have to teach us and accompany all this life course. Before starting, I want to share with you greetings from the Ministry Carla Bisotti and the Secretary of Access and Cuidado, who haven't been able to attend due to their agendas, but really appreciate what we've been working together with PAHO and CLAP in relation to newborn health or perinatal health. A very short summary of the law. It's focused on accompanying, protecting, and comprehensive care of the health and life of the children in the first years of life to reduce mortality and malnutrition, protect and stimulate early relationships and development, to understand health in a comprehensive manner and prevent violence. The challenge of this law is to manage greater intersectoriality, to have more comprehensive policies and with a life course perspective. The authority in the application of this law is the Ministry of Health, and the law demands designing a care model that is specific and appropriate for pregnancy and up to 3 years of life from a strong perspective of the right to comprehensive care, taking into account the specificities of the country. That's a federal complex country with different levels of autonomy in different jurisdictions. This model of care must include cross-sectionally the 3 subsectors of health that in Argentina is something new in this law, in terms of no longer thinking that we should work in a different way in different health sectors. And it considers the creation of an intersectoral coordination unit, including other agencies apart from health working together, and also proposes the need of interjurisdictional agreements that the national state agrees with the provincial states, and these in turn with the municipalities and departments. We've gradually formulated a plan that has been established together with funding and strategies and indicators that can be summarized in 3 policies of admittance with great financial transferences, identity policies, extending the right to identity and creating a centralized registry of birth in hospitals, and comprehensive care access policies, including the need of reporting, training, and approaching violence, and considering the need of specific strategies for these situations of greater vulnerability.
The management of policies is organized as a cross-section. The axes are all women or children to support the Sustainable Development Goals. So we work with the indicators and the practices of surviving, thriving, and transforming. And the approaches are course of life and territorial, and the perspectives contemplate the discapacity and gender. The law also requests using indicators that need to be reported annually in the House of Representatives. We have already created the situation line with regard birth, child mortality, maternal mortality, health determinants, and others such as breastfeeding. And especially we are working in the urgent need of having positive indicators to be able to evaluate the policies. So as a brief summary, and now discussing the most specific related to perinatal and neonatal. In Argentina, similar to what happens in other countries in the region, there's we have a strong reaction of childbirths, almost by 25%. It has been reduced. However, there are still significant inequities in the conditions in which our newborns are born. For instance, if we take the indicators such as the percentage of teenage mothers, we see a very significant variation only if we consider the difference in the provinces, and the same occurs with the percentage of mothers who have not completed their grade school. So we have to focus on those inequalities and try to reach those places that need that really need these policies. As to the 1,000-day plan in the comprehensive prenatal care strategies, if we think of all the population of newborns, we have focused on prevention practices at all levels, and as we said, with intersectoral actions led by this coordinating unit that is already operating. So, and they are based on social health determinants, risk phenotypes, APS as a strategy of prevention, a timely detection of risk, regionalization. In Argentina, this is a policy that is stable, and we are already incorporating to the other risk sectors, interventions and community-based support. And as Fabiana said, nothing about us without, nothing about these population without the population. So as a general strategies at the ministry, we put together an interdisciplinary reference team to for the case of obstetric violence, and there are teams of respected childbirth that are being created to enforce the law. And we are also trying to organize the teams better for the perinatal approach, and we are moving forward in a consensus with a great participation of the scientific societies to guarantee the first hour of life, and also in the safety of our newborns, strengthening research for which we have programs and a purchase of inputs to move forward in breastfeeding with co-responsibility and protection of a safe sleep. In breastfeeding in Argentina, a lot has been done about breastfeeding, but we still have to improve the indicators. The vast majority of the people manage to breastfeed their children the first few months, but then by 6 months, it's very rare. So we are highlighting the co-responsibility to promote breastfeeding and a greater creation and strengthening of the breastfeeding friendly spaces. In the 1000-day plan highlights the importance of the right to information of these populations. And we have agreed among all the agencies that are part of the coordinating unit of this plan. And we have already published the first guideline to reach the constituencies with a common language and so as to meet the needs of a range of people. We are thinking this regardless of whether we come from the education or the health sectors, everybody's involved. And on this website, you have many apps and a lot of information for those who require it. Then going from the most general to the most specific, we have highlighted some priorities. The first is prematurity, congenital heart disease, ischemic hypoxic encephalopathy, and sudden infant death. This is a document that is already consolidated with a diagnosis of the situation, very extensive. It's a document that we have shared and debated and agreed with all the provinces in Argentina. We worked regionally, and this will enable us to make plans adjusted to each situation, to each reality, starting, as we said, with the regions that needed the most, with more inequity. So prematurity is quite a problem. And well, you see how from 2008 to 2020, although the childbirth rate is reduced, the percentage of premature increased by 11%. And there's a great inequality in percentage of prematurity when we compare the provinces. When we observe child mortality here in the neonatal and postneonatal periods, you see that there has been a reduction. It has slowed down. But there are differences between the different countries with very significant gaps, 2.5 points as difference. When we see the burden of mortality due to prematurity, taking birth weight of under 2,500 grams, you see that this has an impact on 50% of neonatal deaths. And there are also great inequalities between the survival rates depending on the province we are speaking about. When we analyze the possibility to see how the prematurity could have been reduced under the current conditions, there's no doubt that the largest number of children who died, especially when we analyze those that can be reduced, were premature, from 24 to 32 weeks, then from 32 to 36. So there's a lot to do in terms of prematurity. And also when we consider the disability related problems, we know that this is very important. The retinopathy of the premature has not been controlled at the levels that we would have liked, despite the fact that we have a program led by the ministry that tries very hard, but we have huge challenges. The objective of this prematurity comprehensive policy can be summarized in 4 big groups. One is to reduce premature births. There we are going to do our best in increasing survival, especially working with neonatal units to reduce prematurity associated morbidities, working a lot with the community and with the different sectors and levels of care, and to prevent prematurity associated disabilities, reaching the social model of disability for all those children that are born with impairments. So, as a summary, what are we investing in for this prematurity policy? We have also expanded the Botiquín Remediar, that's like a first aid kit, incorporating new drugs for the prevention of prematurity, micronized progesterone, alpha-methyldopa, labetalol, to make it available to all pregnant women who need it. In terms of inputs and drugs, there are many centralized procurement for obstetric emergency, for the care of premature babies, and for palivizumab for high-risk prematures. In terms of equipment, in Argentina, we hadn't strengthened the neonatal units for 5 years. Fortunately, now in this new administration, we have invested, and they're about to distribute significant input for extraction pumps, incubators, evoked potential equipment, oximeters, monitors, NeoPAF, etc. We continue to move forward with regionalization of services. We acquired 130 vehicles called 1000 days for the transfer of the patients that require. So we are working also with a team under federal consensus guidelines for antenatal control, phospholipidic syndrome, the monitoring of high-risk prematures, and to approach perinatal death. And we already have a joint planning agenda to work with the management of 1000 days from province to province, starting with those that have the greatest difficulties. A very important program that was launched late last year, the new standards of growth for premature, with 47 neonatal departments that are participating. This is done together in association with the Society of Pediatrics. This is also a great step forward. And work that is done jointly with CLAP is having access to SIP, providing access to SIP plus to all the provinces in the country. Now, another priority is a strategy, the heart malformations national program. We address the congenital malformations that account for 28% of child deaths. There are about 5,000 newborns born each year with a heart disease. And the idea is to give them early access to screening, and we work with a coordinating center from the Ministry of Health. And there are 16 cardiovascular centers organized by complexity of the diagnosis. Since it was created in 2008, 17,000 surgeries were performed in the public sector, and more than 1,574,000,000 pesos have been used there to strengthen the federal network. In 2021, there was a very significant acceleration, and there were only 1,300 surgeries, but now fortunately we are gaining momentum again, and we insist on the timely referral of the patients and investing in everything that is screening in the maternities and the networks organizing the premature, so they won't have to be referred.
We continue making progress in prevention of bronchiolitis with access to palivizumab and extension of access we're about to create the congenital heart disease department for adults. Another strategy aims to comprehensive approach of neonatal asphyxia. Close to 5% of perinatal deaths are due to this cause. And for those surviving, this signifies a heavy burden of disability. We include the RCP national program together with the ACORN program, a new scheme called SEPNEO, and then the creation of the federal network for referral to therapeutic hypothermia, design, acquisition, and distribution of algorithms in the delivery realm, agreeing with the Pediatric Society, investment on equipment. We purchased 440 mattresses for hypothermia and 20 brain function monitors and training for technical assistance. And closing, in relation to specific strategies, a right to safe sleep. It's a specific article in the law. Home deaths are a question. When we observe the course in the past years, it varies between 7 and 10% of child deaths and is close to 20-25% of post-neonatal deaths. In this study that is about to be published, with interviews to families with home deaths between 2018 and 19, the practice of sharing the bed was very high. Only 15% of those who survived had their own crib. The seasonality, it's more frequent in winter. The age was prior to 2 months, and many had a history of prematurity or neonatal care. From the start, we had this work group coordinated by Dr. Benitez, an important neonatologist in the Cerdá Maternity Hospital, together with the Pediatric Society and the School of Design in Buenos Aires and INTI, the National Institute of Technology, agreed to design this handbook of what is currently considered a safe crib. This is the standard Argentine crib where our small baby should sleep during the first 6 months. With this handbook, we will be able to make progress towards a production and distribution of kits for safe sleep to guarantee a higher protection. So the government's or arbitrary measures leave aside this policy that aims to have our children guaranteed the place they will have when they reach the home, and more particularly for prevention of deaths during the early stages. So we have this handbook, and the first cribs will be manufactured by the cooperative agency of the penitentiary service and will be distributed starting in June according to country criteria, starting with children at higher risk and making progress to a universal coverage for all families that are entitled to the subvention or grant for their children. So with this symbol, I really thank you for allowing me to speak to you, and we hope to continue working together with PAHO as we've been doing. Thank you so much. Thank you, Dr. Bauer. Now we'll hand the floor to the video by Dr. Rodriguez de Bukele. Thank you for your presentation. Good morning. Thank you, PAHO, for inviting me to share the actions conducted in the government of Salvador for our children to reduce neonatal mortality. I want to focus on 3 issues. 1, the comprehensive care policy for early childhood. 2, the being born with affection. And 3, the integrated health system. Since we took charge in Salvador in June 2019, we worked for early childhood. This is a political engagement with our children. That comprehensive care policies shapes the road for a multi-sectorial policy for children to reach maximum development potential and to reach a reduction in neonatal mortality by 2030, as proposed in the Action Plan for the Health of Children, Women and Adolescents of PAHO. One of the main pillars of growing together is to strengthen prevention and timely care for newborns to reduce morbid mortality in children and the impact of sequelae generated by premature births, low birth weight, metabolic conditions, and congenital disorders, among others. With progress in 2020-2021, we saw a reduction of 8.6% of premature births and 10% of the number of low-weight babies. Although this is significant, and these figures demonstrate that it is possible, our goals are more ambitious, and we're working hard to achieve them. We've strengthened the neonatal units and changing the approach to make it an open door place where the parents are playing a role in the care of their children. An essential action in the Growing Together policy is food security based on exclusive breastfeeding in the first 6 months that could be prolonged 1 year or two, combined with other nutritional elements, is to ensure what is necessary for the nutrition and growth and comprehensive care of a baby. So we want to protect the mother's milk through the network of milk banks in the country. We've extended this to 3 banks and 55 other milk collection centers. In this way, we benefited 1,500 newborns with risk factors. Mother's milk reduces GI tract complications, hospital stay, and transmits protection factors and prevents then the possibility of having chronic conditions later, and is less expensive and contributes to the environment. It's the best start in life. It creates empathy and support among mothers. In spite of COVID, the number of donating mothers is close to 5,000 per year, and we've had over 2,100 liters of mother's milk. We've included the home modality of donation, and then we have the Kangaroo Care, mother care, ensuring the attachment between the mother and caregiver and the baby. We had 256 newborns with risk factors, and in the 2 specialized mothers and baby care, this has been implemented. In the remaining health centers of the public network, we will adapt areas to refer newborns that will be there to be observed for birth weight. And then we have screening to have a timely identification of genetic disorders that compromise the neurodevelopment. We have screening for hypothyroidism and have benefited 75,000 newborns, will increase to 4 with investment of $1.5 million per year. We're also investing on HIP training with training of human resources to increase coverage to the whole country and purchase equipment to have a timely identification. The idea is to reach 10 health centers this year and complete this by 2024. The auditive screening works in 14 health centers in the national system. On average, we conduct 3,500 tests in newborns with risk factors. The idea is to have this in all the maternities in the health system to guarantee compliance with effective care, including this equipment in the different specialties and a multidisciplinary team for cochlear implant. Thanks to the strengthening of this system, in 2021, we had 40 cases reported with cardiovascular disorders. This is why in the standard we include a guideline for heart training starting this year. We hope that by March we will have the first angiographic material to cut minimally invasive tests. Growing Together promotes timely registry before 8 days of life. In the past 8 years, we have had something like 64 to 68%. And this is significant in the pandemic. The idea is to increase the number of registry with a system automatizing the information in the clinical record of the newborn. We've also strengthened the vaccination system. Every newborn is guaranteed compliance to prevent preventable diseases that could affect their growth and development. In the past year, we've improved storing and get the cold storage to reach a highest number of children. With the system, we want El Salvador children to develop the maximum potential. The law of being born with affection is now ruling, and it's the first initiative of the national policy to support early childhood. In El Salvador, on average, we have 75,000 births per year, and we want them all to be respected deliveries. It's an answer to prevent the identifiable causes producing morbid mortality and disability in children, because it defines general standards and principles for the organization and functioning of the integrated health system to guarantee and protect the rights of mothers and babies with relevant and timely care based on evidence and very humanitarian. The benefit of this law for the newborn is that they will receive affectionate care, will be together with a mother and not separated unless needed for medical reasons to safeguard their lives. Will not receive unnecessary procedures of medical care unless absolutely necessary for their life. Unequivocal identification with a birth or death certificate, breastfeeding in the first hour of life with the possibility of developing safe attachment. Each birth process will be respected without cutting the umbilical cord before 3 minutes and until it stops beating. Skin-to-skin care and joint bedding. When the baby leaves the uterus and receives skin-to-skin contact, it regulates better the oxygen levels, heart rate, and temperature, feels more calm and cries less. And this is better for the immunological system and encourages breastfeeding in the mother. Seen from the human side, the baby is nurtured emotionally because it feels contained and loved and accepted. After hearing the mother's voice and heartbeat, it feels more reassured. This law makes the mother and baby a protagonist together with the family, health staff, and government, so that the pregnancy and delivery experience is positive and magical. To have this policy and the law to work, we need two things: articulated health systems and human resources. The growing together and affectionate birth law include the health ministry, but to have a public system with similar opportunities for all, we need standards and actions throughout the health system. So we've worked together with the health ministry and institutions caring for the social security of workers and specialized research institutes, rehab institutes, and others. It's only together that we'll get all children going forward. If we do so as a country, we create competencies based on maternal and child care we didn't have before. That's why we've updated the knowledge and practices based on scientific evidence, integrated this in the structural changes, encouraging to experience the vocation to provide the best quality accompaniment to children, mothers, and families. First, early childhood really matters. We want a real change in the country. We want to start from the beginning, early childhood. That's why I celebrate the 28-day campaign, Time to Care and Love by PAHO, and this
And the
seminar
implementation of
strengthening
this
of
seminar
neonatal
for strengthening of
policies and
the
actions to
policies
reduce
to
the burden
reduce
of
the burden
disease
of
and disability
disability
in the
in the
Americas.
Americas. Thank you
For
allowing
allowing
me
me
to
to
share
share
what
the
we are
actions
doing in El
conducted
Salvador
in El
as a
Salvador,
policy of comprehensive care for
being birthed with
neonatal
perfection
care
and all the actions and
policies,
institutions
because in
related
El
with
Salvador,
care. In El
each
Salvador,
child
all
counts
children
and each
matter. Have a
child
good day.
matters. Have a nice day. So we go on with Delia. Abelia, if you can, Audelia, if you can start. Yes, thank you. Thank you. Can you hear me? Yes, yes. Well, thank you. Good morning. I thank you for giving me this opportunity to speak about legislation and neonatal screening. And I'll tell you what we have just achieved in our country. I'm Audelia Villarreal. I'm a mother. And as my child was inserted a pacemaker when he was 6 years old in the year 2000, I learned a lot about it. I learned how to make decisions, implementing making decisions that was not used at the time. Today, my son is 28 years old. He has had 3 different pacemakers. He makes his own decisions. He loves sports and music. And this experience led my husband and me to create a new civil organization, Trabajo, that then launched my career and in the Senate. And that is what I'm specialized in the Senate. In the United States, if it was born with a complex heart disease, and his mother founded a newborn foundation and proposes a bill that was adopted in September 2011. So in 2018, we presented in Baja California, my state, and it was approved, and it turned into the first entity in Mexico to have legislation in force in all the state. So I'm going to show you a brief video to show what happened in our state. The children born in our country have the right to undergo a diagnostic test to detect heart problems when they are born. At 7 years after starting the heart screening is in our federation publication. I'm in the foundation Corazón del Niño. In 2014, we started with the initiative for the right of heart screening for all newborns in Baja California Sur. That is how our state was the first entity in the country to have this law. We took this initiative to the Senate in 2018, and in March 2019, it was adopted unanimously. In April 2021, it was also adopted unanimously in the full assembly of the House of Representatives, and it was published in the journal. And so now it's a right of all newborns. Before newborns are discharged, they undergo a non-invasive measurement of oxygenation and may detect a severe congenital heart disease even before symptoms can be observed. This makes it possible to have a timely diagnosis and to gain very valuable time and avoiding crisis due to the heart disease that it can be life-threatening early in life. The congenital heart disease affect more than 18,000 children in our country, and they are the second leading cause of death in children under 5 in Mexico. With this new legislation to recognize a screening, heart screening at discharge, this improves the opportunities for thousands of Mexicans. This is how we implement this right. I want to thank all who made this possible. I want to thank the civil associations, the doctors, the volunteers, the policy makers, the lawmakers, and authorities of the 3 levels of government. So for the next, we're doing this for the next generations. From El Corazón del Niño de Baja California Sur, and from Baja California Sur to Mexico. So this is a video that is very touching for me because, as I said earlier, this is a life story that reached the Senate and transforms everything that I've learned now to expand it to the entire country. In Baja California Sur, we contributed together with other experts. We proposed the draft law, and we managed to have it adopted in the 2 houses and to be published in the reform of Article 61 to the General Health Act. This was in June 2021, and ever since, the children born in Mexico have this right written in a law, and they have the right to undergo this heart screening. This is a simple and low-cost test that may raise awareness in the case of a complex screening, and it can detect 7 critical heart diseases that require care in the early days of life. Today, it is mandatory before discharging the children, and it's mandatory to all the system. It's a pulse oximetry that, if adequately performed, it's an effective test. So it is necessary to have the technical regulations and standardization. In our country, we have an instrument that's called the official Mexican standard that states the mandatory nature of providing these services in the country. And this needs to be revised every 5 years. And we can unify procedures and criteria that may permit to benefit all newborns equally, ensuring that the technical specifications and the procedures are adequate and are enforced. This route that started for Mexico in 2014 and was published in the official publication, this does not finish here. We cannot say that it is ready and it is fully implemented in all the hospitals in the country. So days after the law was passed, they created an experts committee who clarified that their contributions are voluntary, and I am honored to be part of it. In latest months, with the committee, we organized a forum and we presented the algorithm proposed for Mexico and the contents proposed for the Mexican official standard. We presented the cost-benefit analysis, and we delivered it to the Federal Secretariat with over 1,000 signatures supporting it. We started the national training, focusing on local through pediatric organizations and the Mexican community. So in a second video, I'm going to tell you about the cost-benefit study. In this regard, in September, we participated in the forum toward the creation of the Committee for Neonatal screening, we received experts from Latin America for the standardization of this screening. We delivered the Ministry of Health a document signed by 100 experts studying the cost-benefit analysis of for including heart screening, showing that Mexico will be able to save the life of at least 1,000 children every year and will save 12 billion pesos in just the first 5 years by avoiding all the complications that are seen today because of the timely lack of diagnosis. This study that is mentioned today, the Mexican Committee for the Heart Screening Committee, only 29, less than 30 pesos it costs to save a life. 1,000 children every year can be saved once it's implemented as a public policy by the Ministry of Health. And Mexico will save $12 billion in the first 5 years because of all the emergencies that will be avoided by avoiding this, the crisis of the disease. These are significant savings, both in terms of health and economy. Now, we trust that the Ministry of Health will publish this official regulation before July 31st, 2022, as mandated by law, and that may receive hence the budget for its implementation. What are the next steps? The federal legislature and the local policy makers suggest including it in the National Health Act. For the Executive Committee, it implies the publication and implementation of a heart screening in the country and to implement mechanisms and tools for surveillance and measurement for new actions, and as regional activities to establish roadmaps based on the characteristics of each region and to train the staff. Our country has the laws and is about to have all the instruments so that we can implement this screening with all the seriousness and with equality. We are speaking of the right to life that all children have at birth as an essential right. In Mexico, the algorithms and the technical recommendations have taken many hours of work, but they take us in the correct leading direction for the management of heart malformations and for preventive health. We are building public policy with a reality. So the most important challenges that we have faced at a federal level in lawmaking was to make people agree, because it's a test that will increase the work in a country that is not yet providing full coverage. So we need to show that this will be beneficial for Mexico, and this has been a challenge. The process won't be easy, but the balance will be positive, and we can reduce the mortality of this cause and will reduce the risk of permanent disability. So, and in that regard, it's been a challenge so far to convince and to show the true feasibility, the benefit in terms of life saved and the economic savings for the country. At a local level, we have faced problems of supply of equipment and training. We have seen from very close the consequences of not doing it correctly. For instance, in the continuous results of false positives, they can generate in the healthcare staff mistrust, lack of confidence in the system, and this may lead people to skip it. But the most severe thing is what may happen when there is a result that is a false negative in a baby that goes home seemingly healthy and comes back a few days later in an irreversible crisis that may be life-threatening or that may cause a disability in the future. This is a real evidence of how important it is. It is necessary for countries to include official registry of heart diseases to measure the results, to make it possible to assess by prevalence and incidence how we are doing with the benefits of this test.
De la necesidad en general.
And what is happening with coverage of needs in general. Expected outcomes include several items. We must continue progressing with heart screening at neonatal level, and this should become a new starting point for a new route for comprehensive care of congenital heart disease in Mexico.
Nos vaya a llevar. Lo que sí sé.
I don't know how long it will take, but we've made progress since 2014, and each step is a new opportunity. And concluding the route of neonatal heart screening, we will comply with the Constitution, the General Health Law, and the law for the health of children and adolescents, and all the standards we have that must be published. Speaking of the congenital defects at birth, perinatal health, and newborn health, we must be aware that the executive and legislative issues and civil society issues are all one and are closely related. And this is why this event is extremely important, because it gathers different standpoints that make visible the common goal and a need to have strategies, to have a clear route to drive this forward. Neonatal screening in general, metabolic, extended, auditory, visual, and cardiac are the path to preventive medicine, and this for better quality of life. Screening should be a starting point for equality at the start of life. On behalf of my country, the Heart of Children, and the Mexican Committee for Neonatal Heart Screening, we make available all the knowledge we have gathered in this path. Thank you. Thank you, Mrs. Villarreal Zavala, for your presentation, and of course, for the excellent presentations we've heard today before. These presentations are really motivating, very rich, and clearly framed within this initiative that CAP and the Family Health Promotion and Life course, together with CAHO, have been working on, and to which we will refer right now. The raison d'etre for this process and the previous presentations give a clear support for the need for a comprehensive approach. And this arose from the analysis of the burden of disease and disability associated with perinatal events, and particularly to the need for promoting and strengthening and counting with policy strategies and interventions geared to improve the health, development, growth of all newborns, and more specifically with an active participation from the different players. It is in this framework that we began to consider this process addressed, as we've observed, to health professionals and individuals engaged with the creation of policies and laws related to health, but in general, managers, health teams, researchers, and indeed families and civil society in general. And in this sense, and as discussed in the different presentations, we do have global and regional frameworks such as the Sustainable Development Goals, the World a health strategy for women, children, and adolescents, or the framework of surviving and thriving to transform the care of all newborns, in particular premature, small, and severely ill babies. And in the Americas, the Action Plan for Women, Children, and Adolescents Health 2018-2030. These frameworks promote and have the support from the member states that have adhered to reduce neonatal mortality and child mortality, and for other population groups, but essentially from the perspective of reducing the significant inequalities we have in our region. In this sense, the COVID-19 pandemic has worsened a situation we already considered a challenge. So it is in this framework, and although we don't have enough data allowing us to quantify its impact, we do have evidence showing that the direct impact and the indirect impact of the COVID-19 pandemic will worsen the conditions regarding newborn health. So, this initial working document has the aim of triggering a discussion and consensus to strengthen and extend policies to allow a substantial improvement in outcomes in perinatal health in the region, supported, as was clearly and manifestly highlighted in the previous presentations, from the perspective of rights, equality, and in line, of course, with the commitments for 2030. We are aware, and this has been discussed at individual level and in the families and governments, that the burden of disease, mortality, and disability related to perinatal events is extremely high. Among the 20 conditions contributing to the burden of disability as measured as years of life lost, of healthy life lost, perinatal outcomes and congenital defects are two of the 20 main groups of causes. Both, in summary, constitute over 15 million years lost, according to WHO estimates in 2019, because of these conditions, many of which, as stated, can be prevented. So the question is, what should we do? And we've had excellent presentations regarding the possible paths for action. Excuse me? He's trying to share the screen, I think. Which are then the possible paths for action? We can't see the presentation, I'm sorry.
Ahora está entrando. Eso es. Gracias.
Yes. Entonces, en virtud de lo dicho hasta
Because of what we've heard, the question is, what must we do? What can we and what should we do? First, we've heard about the relevance of these perinatal conditions and the urgency they entail from the individual and family standpoints, but also at community level. And this is very important. Relevance and urgency that set the need to strengthen the political agenda and leadership in the different players to accelerate the different processes. We're aware that many of the perinatal adverse conditions may be prevented. There are resources, interventions, and knowledge, allowing an impact to eliminate preventable deaths, but also improving and strengthening survival and quality of life of newborns. So in the framework of the goals of surviving, thriving, and transforming, so that the newborns reach their maximum potential, we have summarized 10 lines of intervention allowing progress in this sense. And we will share them with you. The lines of action we've seen in different combinations and measures in the previous presentations. First, universal health coverage across the life course. We're quite convinced that ensuring that we have equitable access to quality health services in a comprehensive manner in general terms, but more particularly in individuals with higher risks for health. And here we highlight newborns and more specifically premature and severely ill premature children. So we know that universal health coverage is essential. And this, of course, to reach it, we need partnerships, solid partnerships with health professionals, families, and also leaders and decision makers in the different countries in order to obtain the best outcomes, bearing in mind the vulnerability conditions that are specific to the different situations. Another action is related to reproductive health and preconception care, integrating the provision of services and educational supply in the life course from the preconception stage is extremely necessary. We are aware of the positive and negative impact of environmental events, exposure, and health conditions, even prior to conception and even before in girls and teenagers throughout the life course, that are responsible for many conditions that will impact on the child during their growth, but are responsible for the burden of disease due to chronic conditions. And also, from the rights standpoint, we are aware that health policies that ensure the health at preconception level are extremely necessary. And in a similar sense, care during pregnancy and labor, following the life course path, is essential to encourage interventions and investment to improve access to quality care at the time of birth and ensure that women's rights, respect, and dignity are maintained during pregnancy and birth. In this sense, by way of example, and this is a summary of policies that includes the recommended policy and resources available, WHO recommendations on antenatal care for a positive pregnancy experience, or the WHO guideline counseling of women to improve breastfeeding practices and respectful maternity care charter are essential. The care and promotion of breastfeeding is essential, and this at preconception level. And of course, as a fourth item, we must include essential newborn care with updated targets for reducing newborn deaths and disability and their inequities. For eliminating deaths due to preventable causes. This is included in regional frameworks, particularly the Health Action Plan for Women, Children, and Adolescents. So there's a call to update these targets and not only consider a reduction of averages, but also inequalities and gaps inside the countries. This is a reason for this call to update these goals, particularly in the framework of the COVID pandemic that, as stated, has impacted and in some cases gone backwards.
Metas, transformar el cuidado y
And
los
to achieve that, to transform the care, to promote the health of premature, smaller and severely ill is essential for all newborns to design and implement specific plans for, as we saw some examples, for provision of comprehensive inpatient care and intensive care, and especially those that are born too small or sick that require special care. Third, well, we talked about newborns in general, but the premature and the sick, this involves the need to strengthen this from a family-centered perspective, with a perspective of an integrated care. And it is important to highlight access to essential medication and health perspectives, and because part of the inequalities are have to do with the access to essential drugs and health technologies. And if we know that the complications of prematurity and retinopathy, sepsis, infections, or congenital defects account for the most deaths, having the resources, drugs, and technologies in integrated networks of healthcare is a priority. The sixth line, and again going back to a comprehensive intervention, that is the promotion of breastfeeding. We recognize the essential need to strengthen surveillance and full implementation of the codes for the marketing of maternal milk, and to develop policies to promote maternity leaves for the families where the mother works. But even those who are not in formal, do not have a formal job, to strengthen and protect the start and the maintenance of breastfeeding. A few days ago, the WHO launched a study showing how marketing is an influence for the decisions, and how it creates constraints. So this is absolutely necessary, together with other strategies for premature and sick newborns, such as the human milk banks and other strategies for the promotion. And so all this demands active policies, laws, but also the involvement of families and caregivers. And continuing with these lines, the seventh is the nurturing care. That this is a framework that UNICEF, WHO, and other partners promote. This implies promoting in the first stages during pregnancy and early childhood interventions for all newborns, investing in essential care for the development of health and for early childhood in a favorable manner, promoting the family centered care and in a comprehensive manner. But we cannot forget, if we talk of rights and equity, we need to pay special attention to those newborns that are born under humanitarian crisis. And we know that in our region, there are migrants or people that suffer because of a climate or other type of emergencies, and require the availability of integrated plans, ensuring an optimal care for these newborns and their families because of the dual vulnerability, because of their condition of newborns, more specifically if it's a premature or that is sick newborns, but also because of the vulnerability, because of the emergency. So we need to consider the documents and the existing material for implementing actions in this context that is essential in when we consider policies for strengthening health of newborns. As the ninth action, we'd like to highlight, and this is something that was also mentioned in the different examples that we saw in the countries of the region, the strengthening of the staff that provides care to newborns and their families. When we speak of essential healthcare workers, we speak of all the workforce, including nurses, doctors, but also the various disciplines that, as we know, collaborate for the newborns care, especially when they present some of the conditions that we mentioned. And this situation we know is critical in our region. It's critical because of the lack of human resources, because of the constraints for limitations to training, evidence, because of the rotation of the turnover of the staff, and because of the lack in some areas in the country. So we have to invest in the workforce to ensure quality services, and this is a key thing. And with the peculiarities in the case of newborns, to emphasize the care of the premature and sick babies. And this last item, the multi-sectoral approach and civil society engagement, that is, we need multiple sectors, multiple stakeholders to participate, with the commitment of the civil society that needs to be actively engaged. When we implement these policies, we need to get the greatest commitment of the different players. We need the collaboration of fathers, mothers, and caregivers, and the different social stakeholders. PAHO sustains the framework of health in all policies and the building health throughout the life course, concepts, implications, and application in public health, or the plan of action for women's, children's, and adolescents' health. And we need to include then the economy, social, and health related issues. So as a final remarks, this summary of the policies is essentially a working document, and it intends to contribute to the debate about policies aimed at promoting so this would be the first step of a roadmap to increase the visibility to the importance of focusing the care surrounding birth and a newborn, and to strengthen, expand, implement, monitor, and evaluate these policies with an integrated perspective. These working lines were developed based on an internal discussion at CLAP and with colleagues that have contributed in the analysis of the burden of disease and disability, and also the summary of policy, Guillermo Macias, several professionals, but including the different departments of a PAHO, of non-communicable diseases, mental health, Department of Services and Health Systems, the drugs, medications, and family promotion and course of life, the legal department, the Department of Statistical Analysis, communication, as well as centers that collaborate with us. But essentially, this is the first step, after which And from now on, we want to ask you to help construct a roadmap that at a regional level, but also at a country level, may enable us to move forward having comprehensive policies for this. So thank you. I now give the floor to Dr. Sarruya. Thank you. Thank you, Pablo. We are going to go on. Now, I see that the other speakers and you too, Pablo, I want to thank the excellent the speakers for the excellent presentations. I just received a comment from Maria Luisa Vasquez, who wants to send everything to the people who work with her in her department. So we are live in YouTube. So the videos remain in YouTube. So I'm going to do how all YouTubers do. Please like it and share it, because that helps us reach more people more equitably, and so that people may know the different, or may hear all these lectures. So from all my heart, as the director of a club, I want to thank Fabiana, a friend, a Brazilian that, like myself, is abroad, away from home, working for the health of children. And also Dr. Gabriela Bauer, who spoke from Argentina, a country that gives us so many examples. And they've given us Pablo, who's from Argentina too. And the senator from Mexico, we were all so excited about her work. And the First Lady of El Salvador, who sent us the video. I think that Dr. Gabriela Rodriguez, that showed you the power that the political and technical authorities may have in your countries. And finally, I want to thank Pablo, who implemented this campaign that is so important emotionally. It's time for nurturing and caring. It's 28 days, and we know of the importance from the developmental point of view, how important it is for the newborn that comes to the world. Now I went back to the app. If you that are listening us, you can download this app. This app, of course, is free of charge, and it is very helpful to people. It helps mothers, fathers, and it is very important for us, for you to use it and to send your feedbacks. What is it that you found about this? So I really want to thank the speakers and Pablo, who is our regional advisor, and to thank everybody that is behind the cameras, the translators. We have the coordination, Ana Artigas and Porro coordinate this. And we also have the people in charge of streaming. We always have somebody new. Today, we have Juan, who gives us support, so that we may have 3 languages, different rooms, etc. So all of you, thank you for your participation. Don't leave, because Ana, together with the countries and Pablo, organized a very nice video that brings the experience of several countries. But not just mothers, but fathers as well. So thank you for being with us from CLAP. It's been a real pleasure to be with you. And I leave you with the video. See you.
Y una vez me habían dicho que el amor se multiplica, y es así. Es muy impresionante la sensación del amor profundo, como te atraviesa.
Dos bebés, doble cuidado, por ejemplo con el tema de la alimentación. Tengo que anotar cuánto le di, cuándo le di, también pendiente de las vitaminas que hay que darle, o la curación del ombligo durante los primeros 10 días.
Bueno, al final lo que le pedí a mi mamá porque no cobraba las obras que estoy cerrando, me cansó.
Hasta el momento sigue tomando su lactancia, su leche materna.
La semana que viene pensaba. Hace que vengo con la lengua afuera y tengo deseo y alguna otra cosa. Llámame si podés y vemos, si no, veo cómo arreglo. Eso. Bueno, como mucho creo que serían $1000 para paliar el panorama.
Borja, mi bebé, pero con muchos primos, muchos tíos, muchos abuelos amorosos que estaban deseosos de que llegara y no se encuentran palabras para algo tan inmenso.
Nos dio COVID a mí y a mi mujer, pero había que estar al pie del cañón y levantarse de la cama con 39 de fiebre. Lo que a mí me demostró el nacimiento de Martina, el contexto, es que el amor por una niña genera fuerzas infinitas.
Foi o dia mais feliz da minha vida, mas também foi o dia mais preocupante da minha vida. Eu tive vários cuidados em relação à pandemia. Eu só permitia visitas a pessoas mais próximas mesmo da família.
Desde que llegó Lucas me cambió la vida para algo muchísimo mejor, me enseñó a luchar más por todos mis sueños. La verdad que yo llamo la maternidad como algo, una experiencia caóticamente hermosa, algo que te cambia pero es para mejor siempre.
Pues sí, qué manera él pueda crecer más sano, de una manera que nada le afecte, pero creo que lo voy a ir aprendiendo poco a poco.
Fue como una nueva oportunidad que nos daba la vida para dar y para recibir amor. Ese motor nos llevaba a seguir formándonos para hacerlo bien.
No tenía leche al principio, ¿no? Y cuando ya empecé a tener la leche, pues el bebé, como era prematuro y chiquito, no tenía fuerza para succionar. Hasta que al 5º día empezó pues a agarrar un pecho y al 10º día el otro pecho, que eso ya fue un alivio para mí.
Como que el cuidado más importante que he tenido es traspasarle toda la tranquilidad y el amor del mundo. Mudarla, hacerle cariño, darle comida, preocuparme de que su piel esté suavecita, pero principalmente de darle amor.